Hello everyone, I'm Dr. Sandeep Sharma, your pediatric faculty. And this video, we are going to discuss the FMG July 2024 Pediatrics Recall. I have tried my best to collect the best possible recall. Where options were not available, I have tried not to mention them. At the same time, almost 18 MCQs we are going to discuss, which were asked from pediatrics in July 24. Two of the questions are contentious. So I have tried again to find the best possible data for them. But it is important that all of you students who are listening to this and will be appearing in future exam, you understand the topic per se, and the values will always be different. You can always change the value and reach the appropriate answer according to the question, right? So without wasting any time, let us start with the discussion. So this is a disclaimer. This is based upon recall of students. Even a single word shifts from here to here and the answer will change. Any resemblance to actual MCQ is coincidental. The purpose is to guide you in planning the MCQ revision better. And I have tried to use the latest references wherever possible. So let us start with question number 1. A child has been diagnosed with congenital hypertrophic pyloric stenosis. So we are dealing with the case of CHPS, also called as idiopathic hypertrophic pyloric stenosis. In my classes, in my lectures, I always tell you that this is a almost sure topic. Every alternate year it is asked. So they are asking which of the following metabolic abnormality needs to be treated in this child. Basically, what they are asking is which metabolic abnormality will occur in the patient. So whatever metabolic abnormality happens, you will be treating that, right? So CHPS is characterized by, now 4 options are given here. CHPS is characterized by persistent vomiting. So what is CHPS? Details we will not be discussing here, but a brief overview is important. After birth, there is progressive hypertrophy of circular smooth muscle of the pylorus. So if this is your stomach, this is the part where pylorus is there, and there will be progressive hypertrophy of the muscle leading to obstruction of the lumen. This obstruction of the lumen means whenever child will consume milk, the milk will not be able to pass into duodenum and there will be reflux bag. And this will come out as persistent vomiting. This persistent vomiting is projectile. This is non-bilious and it is typically triggered by feeds. So it occurs post-feeding. Such type of vomiting is the hallmark in the patient. This vomiting can cause multiple problems. Majorly, it will lead to the development of hypokalemic metabolic alkalosis. And that is the most common abnormality that you will find. In fact, alkalosis is considered to be the cause of death in patient of CHPS. Now try to understand why would this happen. Whenever child will be doing multiple vomiting, there will be loss of gastric juice. Gastric juice has hydrochloric acid. So loss of hydrogen and loss of chloride is going to cause hypochloremic alkalosis, right? Because hydrogen ion is lost, so bicarbonate will become excess. So there will be hypochloremic alkalosis. Apart from this, initially there might be some sodium loss happening, but that sodium loss can trigger renin-angiotensin axis activation, leading to aldosterone production. And due to secondary hyperaldosteronism, what we find is that there is sodium retention leading to no hyponatremia, but potassium tends to become low if vomitings continue. There is some potassium in the gastric juice also, and some potassium there in the, it occurs due to aldosterone activation as well. So to keep it simple, alkalosis will be a complication. Chloremia, hypochloremia, loss of chloride will be a complication. And in long-standing case, hypokalemia will also occur. Hyponatremia does not occur in CHPS. This is a very key point, and I have discussed in my video lectures also, with your face-to-face classes also, and whenever I have discussed this topic. So have a look at the options. Hypophosphatemia is not known. Hypomagnesemia is not known. I just told you hyponatremia does not commonly occur in CHPS. What you find is hypochloremia. Suppose this question did not have hypochloremia and instead hypokalemia was mentioned, even then hypokalemia will become the better answer. But if you have both, say imagine both of them are mentioned, your better answer will still be hypochloremic alkalosis, because hypochloremic alkalosis is the typical abnormality which has been mentioned in Nelson 22nd edition as well. So my purpose in this recall is to give you an overview. I will be telling you what is the answer, and where appropriate, I will be telling you why others are not the answer, so that your understanding of the topic is very clear. So question number 1, the answer is D, hypochloremia. Then we look at MCQ number 2. There is a child who presented with strong upper limb pulses and weak lower limb pulses. What is the likely diagnosis? Now it's a simple one-liner kind of a question. There is strong upper limb pulses and weak lower limb pulses. It occurs due to a condition known as coarctation of aorta. Why coarctation of aorta? Suppose this is the arch of aorta. You have the brachiocephalic trunk arising from here, giving rise to right subclavian artery and the right common carotid artery. Then you have the left common carotid artery, and then you have the left subclavian artery. The most common site of coarctation of aorta is somewhere over here. It is distal to the origin of left subclavian artery. This is called as the juxtaductal coarctation. If someone asks you which is the most common type of coarctation, juxtaductal. Coarctation ka matlab kya? What is the meaning? Coarctation, narrowing or constriction in the arch of aorta. Now see what will happen here. Whenever there will be an obstruction like this, now there is an obstruction which has happened. So the descending aortic blood flow will be compromised. The blood flow in this region, will be more, and the blood flow in the distal region will be less. So the upper limbs will receive a more arterial blood supply, leading to hypertension in upper limb, hypotension in lower limb. Strong pulses in upper limb, weak pulses in lower limb. Long-standing cases, asymmetry between upper and lower limbs can occur, and you will find, due to the development of collateral circulation, radiofemoral delay will also occur. So it is a simple concept here that if there is a congenital heart disease being suspected and there are strong upper limb pulses and weak lower limb pulses, coarctation of aorta is the diagnosis. So if you get future MCQs, so what are the clues in congenital heart disease that you need to know? If the MCQ says asymmetry between upper limbs and lower limbs, if the MCQ says radiofemoral delay, one or more of these features can be mentioned. And if they say good pulses or hypertension in upper limb plus poor pulses and decreased BP, hypotension in lower limb, in all these cases, the diagnosis will be coarctation of aorta. You can remember for future exams. Also, if the MCQ says asymptomatic patient and the child is having no CCF, but there is presence of wide fixed splitting of second heart sound, so your answer in such question will be atrial septal defect. If the examiner says there is a child who's having congestive cardiac failure, infections, and a pansystolic murmur, there is a pansystolic murmur along with cardiomegaly happening in the patient, and the age of the patient is between 2 to 4 years. Rarely it can occur in infancy also, and rarely it can occur in older age also. The likely diagnosis will be VSD. In fact, VSD can have a manifestation even as early as 2 months onwards. Right? So answer will be VSD. And if the MCQ says an infant is having this kind of presentation, there is CCF, there is pneumonias, and there is a continuous murmur called as continuous machinery murmur. In such patients, the likely diagnosis will be PDA. And finally, if the MCQ examiner is saying these kinds of case scenarios are very important for FMG perspective, because examiner is not asking you hemodynamics. Examiner in FMG exam is generally asking you to make the diagnosis or identify which of the following is present or not present in this important heart disease. So if the examiner says cyanosis, and cyanosis improves by squatting position, sometimes not squatting, but knee chest position will cause some improvement in the cyanosis because it decreases the right to left shunt. Examiner says boot-shaped heart, also called as 𝗂𝗽𝗱 and 𝗂𝗽𝗱𝗁, but there is no cardiomegaly, normal sized heart. that is a normal CT ratio. In such patients, diagnosis will be TOF, tetralogy of Fallot. So these are the clues. You can take a snapshot, or you can take a photograph, or you can write it down somewhere. Last 1 week also, have a look at it. You will get confidence if you get a similar MCQ in the exam. Moving further, MCQ number 3, it's a very easy one. Which of the following channel defect is present in CFTR gene abnormality? CFTR stands for cystic fibrosis. The full form is cystic fibrosis transmembrane, also called as transconductance regulator. It codes for a type of epithelial chloride channel. And the absence or dysfunction of this chloride channel is responsible for producing the disease called as cystic fibrosis. So which channel defect is present in CFTR gene abnormality? It is chloride channel. Remember that CFTR gene, past MCQ, FMG exam, it is present on chromosome 7q. It's a mistake people make. It is not 7p, it is chromosome 7q, where CFTR gene is present. Long arm of chromosome 7, it is present. So I'm discussing the question, and if some past MCQ related to this, relevant to that question also comes, I will be labeling it that as well. Then we have MCQ number 4. 2-year-old child has fever and cough for 2 days. Examination revealed a respiratory rate of 44 per minute, and there is chest retraction. Child is able to drink and feed normally and has normal SpO2. What management needs to be done? Now you need to see carefully here. This is a child less than 5 years, and any child less than 5 years who has fever or respiratory symptom, here both are present, acute onset, you will think of possibly pneumonia. Now, whenever you have to make the diagnosis of pneumonia, you will be following the IMNCI guidelines. So IMNCI guidelines say you look for fast breathing, chest indrawing, and danger sign. So does this child have tachypnea? Yes, the child has tachypnea because the respiratory rate equal to more than 40 per minute in age 1 to 5 years is called as tachypnea. Here it is 44. So the child is having tachypnea. So tachypnea is present. Chest retraction, that is chest indrawing, is present, but no danger signs are mentioned. So the child is likely to have pneumonia. And in pneumonia, oral antibiotics are given. You explain danger signs, give antibiotic amoxicillin for 5 days, but review the patient in 48 hours and send them home. So answer to this question is B. Very similar question we have discussed in the classes as well as in the video lectures. But this is a topic which is too important to be left alone. So let us do a rapid fire quick review what you need to know in pneumonia. So diagnosis and treatment, latest IMNCI guidelines, this to save time. So because if you are watching this recall, you might be watching it close to the exam as well. So I've written the key points myself. I'm not taking some textbook photograph. Textbook photograph, I will show you afterwards. First, you need to understand, any child aged less than 5 years comes with fever or respiratory symptom like cough. First, you define fast breathing, whether it is there or not. So these are the cutoffs. Then you see if the chest indrawing or chest retractions are present or not, and then see any general danger signs are present or not. These are considered the general danger signs. In addition, if there is SpO2 less than 90%, or in case patient is having stridor in a calm child, stridor at rest, that is also considered to be a danger sign. So if there is no tachypnea, no chest indrawing, no pneumonia. If there is tachypnea or chest indrawing, pneumonia. And if there is any danger sign, we call it as severe pneumonia, right? So remember the funda: no tachypnea, no retraction of the chest wall, and no danger sign. That will be labeled as no pneumonia. In no pneumonia, no antibiotic is needed. In case either there is tachypnea, that is fast breathing, tachypnea is the other name for fast breathing, or chest indrawing, the answer will be pneumonia. And if there is any danger sign, you will label the patient as having severe pneumonia, which is also called as very severe disease. Now, what to do in them? I will show the screenshot of a textbook, the latest IMNCA guidelines. Now, have a look here. These are the guidelines you need to remember. So, no pneumonia, no need for antibiotic. You give a green color code. If there is fast breathing or chest indrawing, if or both are present, you give a diagnosis of pneumonia. Give amoxicillin for 5 days, oral antibiotic. And any danger sign or stridor at rest or SpO2 below 90%, severe pneumonia, also called as very severe disease, give first dose of IV antibiotic, refer to higher center, make sure to give oxygen to children on the way to hospital. You might have seen those kind of ambulances also, where ambulance is written, it's a omni van and there is nothing inside. So being medical officer tomorrow, it is your duty to check if oxygen is available and oxygen delivery apparatus is available or not. Right? So practical point also, because tomorrow all of you are going to crack FMG, do your internship, and then contribute to the society as doctors, right? So this is a very, very important topic. Let us move further, talk about the next question. In the next question, MCQ number 5, a male child aged 6 years has difficulty in standing up from sitting position and he has a positive Gower sign. So if a child has difficulty in standing up from sitting position, it might indicate proximal muscle weakness. So there is a child who's having, what are the clues here? Proximal muscle weakness. Second, there is a positive Gower sign. What is Gower sign? Child climbs upon his own body to get up. And what is the gender? Male. So something happening majorly in males, which indicates X-linked recessive condition. So likely query, X-linked recessive. And age between, in the first decade of life, the symptom has appeared. Everything is pointing towards a diagnosis of DMD, Duchenne muscular dystrophy. So the patient is suffering from likely Duchenne muscular dystrophy, which is the answer, right? So patient is likely suffering from Duchenne's muscular dystrophy. So you can have a look here as well. Let me just show you again. Now you have a look here. So this is the typical Gower sign. They can show this photograph tomorrow and ask you, where is this sign found? Gower sign indicates proximal muscle weakness of the hip girdle, that is the lower limb. It was originally described in patients of DMD, but we know it can occur in other conditions also where proximal muscle weakness is there. So for example, dermatomyositis or juvenile dermatomyositis, this sign can also be present. So answer here is D. Remember that Gower sign can be positive in not only DMD for future exams, it can also be positive in dermatomyositis. So याद कर लो, कहीं पर लिख लो. Tomorrow you may get Gower sign positive, but they will not mention DMD, and then you will be in a soup. You have to be mentally ready that if DMD is not in the option, Duchenne muscular dystrophy not in the answer, dermatomyositis will be the likely answer. Moving further, MCQ number 6. A baby is having dry skin, delayed tooth eruption, macroglossia, and umbilical hernia. What is the likely diagnosis? So large tongue, dry skin, umbilical hernia indicating axial hypotonia, and delayed tooth eruption. My dear friends, I have discussed in all my classes, I discussed in my videos also, that delayed tooth eruption is defined as no tooth erupted by 13 months of age. Mostly idiopathic. Two other causes are there, rickets and hypothyroidism. So which out of them will have delayed tooth eruption also, large tongue also, umbilical hernia also, and dry skin? It will be hypothyroidism. So hypothyroidism in a child, in a young baby, produces a clinical state known as cretinism. So the child is likely suffering from cretinism. So what are the key points you should remember for the exam? Remember that there is also another entity called as endemic cretinism, which is different and which has predominant CNS symptoms. Cretinism generally refers to hypothyroidism. So whenever there is hypothyroidism or cretinism-like features in the patient, what will be the, if basically hypothyroidism persists and severe, leads to a clinical state called as cretinism. So in hypothyroidism, how to identify, what will be the clues examiner will be giving in the MCQ? First of all, they will say prolongation of neonatal jaundice. Normally, we know that neonatal jaundice, even if physiological is there, it will disappear in 1 to 2 weeks. But prolongation of neonatal jaundice is one clue. Second, posterior fontanelle. You know, there is anterior fontanelle and posterior fontanelle. The posterior fontanelle normally closes at birth or it closes soon after birth. If there is persistent open posterior fontanelle, that is another clue. Third, these patients will have umbilical hernia as a clue because of hypotonia of the abdominal muscles. Then they will have decreased tone of the muscles in general. So hypotonia in general will also be there. Then these children will have dry skin, brittle hair, and these children will also have delayed tooth eruption. Delayed tooth eruption. Last but not the least, these patients, the features are non-specific, but they will also have a hoarse cry and large tongue. Large tongue means macroglossia, right? So these are the features which are suggestive of hypothyroidism in the patient. So evaluate thyroid function test urgently. Moving further, MCQ number 7. What is the mid-parental height if a male child has father with height 160 centimeter and mother's height of 145 centimeter? Now, what is the funda of mid-parental height? Mid-parental height is utilized to calculate the likely age of a child when he or she will become adult. Generally, it is assumed that height of a child depends upon the height of the parents. And if both father and mother are tall, the child is also likely to be tall and vice versa. So there is a formula known as mid-parental height, which is given. Mid-parental height says that what is the expected height of a child. It tells you about the expected height of a child. If you have to calculate a male baby, the formula is father's height in centimeters plus mother's height in centimeter divided by 2, keep in bracket plus 6.5. And in case of females, that is girls, the formula will be father's height plus mother's height minus 6.5. And this is what you are supposed to apply here. So number one, you had to know the formula. And number two, you had to see whether it is a boy or girl to add or subtract 6.5, right? So let us calculate here. It is a male child. So in a boy, the father's height is 160 plus mother's height is 145 divided by 2 plus 6.5 we will do. So that is going to be the expected height of a child. So let us calculate 160 plus 145 by 2. It will be 305 divided by 2 plus 6.5. So it will be coming to 152.5 plus 6.5. So what is the answer? 159 centimeter. And that is the answer. So where is the option D given? Yes, this is option number D, 159 centimeter. Some of your seniors and some of the people who are listening to this video, you marked a 152.5, taking the average. In a boy, add. In a girl, subtract. So if it would have been a girl, so we would have subtracted 6.5 from 152.5, and so there some value of 146 or so around that value should have come. So MCQ number 7, this is how you are going to calculate numerical. This exam had a lot of numericals, so get your mathematics right. In case you are running short on time, in the actual exam, from what I've heard, calculator is given to you, not physical one, but it is there on the screen. But know the formula, that is more important. Move further. MCQ number 8, easy one. Indirect MCQ. A neonate presented in the first week of life with feed refusal, recurrent vomiting on breastfeeds. Glucose administration is tolerated normally by the child. So when the child consumes mother's milk, milk causes vomiting, and the child is not taking the milk because he is getting restless, he is getting a toxic reaction. But glucose produces no intolerance. It means it is a metabolic defect where there is milk intolerance causing a violent reaction. This is nothing but fitting into galactosemia. Galactosemia. Glucocerebrosidase deficiency does not present like this. It is not phenylketonuria. There is no hypopigmentation or CNS problem. Aldolase B is related to fructose metabolism. There is no fructose digestion here, fruit juices here. The answer here is, which is the likely enzyme deficiency, GALT or GALPUT. GALT or GALPUT are two different names of the same enzyme. Galactosemia is a condition in which there is deficiency of enzymes required for the digestion of galactose. You have epimerase, you have galactokinase, and most important, the enzyme deficiency which causes classic galactosemia, that is galactose 1-phosphate uridyl transferase. And this enzyme is sometimes written as GALT, sometimes it is written as GALPUT. So ये दोनों अलग-अलग नाम है. These are two separate names for the same enzyme. And this enzyme deficiency produces classic severe galactosemia. So answer here is GALT or GALPUT. Remember that galactosemia is absolute contraindication for breastfeeding. And this is a past MCQ point even in FMGE July 23 exam. Moving to MCQ number 9. A milestone question. Calculate the likely developmental age where the child is able to ride a tricycle, climb upstairs with alternate steps independently but is unable to hop. Riding a tricycle comes at 3 years of age. Climbing upstairs without support, alternate feet, comes at 3 years of age. Climbing downstairs alternate feet without any support comes at 4 years, but that is not mentioned here. Ability to hop. Hopping comes at what age? Ability to hop on one foot, that comes at 4 years of age, and on both foot, that is skipping a row. It is called as skipping a row. That comes at 5 years of age. So the child is able to do milestones related to 3 year, but the child is not able to do milestone related to 4 or 5 year. So age should be at least 3 year or more, but less than 4 year. And what is the option there? 3.5 years is your answer. So applied question, but a useful development milestone. My dear friends, development milestone almost always asked in some way or the other. So please be thorough with the milestone and also practice the MCQs. MCQ number 10, one-liner, I will not go into detail. Exclusive breastfeeding is recommended till what age? Till 6 months of age. If they ask you, it should be started ideally after birth, how much time? ASAP after birth. ASAP means as soon as possible after birth. But according to WHO as well as UNICEF, WHO and UNICEF say that it must be started within 1 hour of birth. Right? And it is given till what age? Given till what age? It is given till 2 years of age. So 6 months tak to exclusive breastfeeding hai. After that, you will add after 6 months of exclusive breastfeeding, you will add complementary feeds to the patient. So it should be an age-appropriate funda. Now, very, very important thing. Please add it to the notes. It's a useful guideline mentioned by American Academy of Pediatrics, likely to be incorporated in the new textbooks whenever the new editions come. Please add, and also remember for your practice point for later life that any child where you give complementary feeding, during complementary feeding, जब 6 महीने के बाद start करते हो, so make sure that no salt is given till 1 year of age and no sugar is given till 2 years of age. This is the rule that we follow while giving complementary feed to the child. But we all know the reality. क्या होता है, and parents have a tendency to give sugary and salty things to the child, but this is something that you should be advising. MCQ number 11. There are two versions of this. I have taken both the versions. Options were same. So one version said, some students said, sir, which is the IV fluid of choice in a child who's having diarrhea with severe dehydration? And second group of students said, what is IV fluid of choice in a severely malnourished child with diarrhea and severe dehydration? So remember the funda. If it is IV fluid of choice in diarrhea and severe dehydration, it will be Ringer's lactate. But if they say severe malnourished child having diarrhea and severe dehydration, the answer will be Ringer's lactate in 5% dextrose. Ringer's lactate in 5% dextrose. I'm not marking here. I'm mentioning it here. Depending upon what has been asked, you will be marking accordingly. Let us move further. The next MCQ, in a child with neonatal jaundice, which of the following will have unconjugated hyperbilirubinemia? Let us go stepwise. Biliary atresia produces conjugated hyperbilirubinemia. Dubin-Johnson syndrome causes conjugated hyperbilirubinemia, and that also does not occur in the newborn. It occurs in childhood, adolescent, or adulthood sometimes. Rotor syndrome also causes conjugated hyperbilirubinemia. Gilbert syndrome as well as Crigler-Najjar syndrome are associated with unconjugated varieties. And so D is the answer. Remember, biliary atresia, there was a January question that biliary atresia should be suspected when? Biliary atresia is suspected if there is jaundice, neonatal jaundice lasting more than 2 weeks. Along with there is this cutoff had been asked, along with dark colored urine and clay colored stools. And then you will get an ultrasound, look for the typical signs, and you can do a HIDA scan. Liver biopsy can be done, but the gold standard is peroperative cholangiography. This is related to biliary atresia. These are the additional points you can remember. But in this question, the answer is D, that is Gilbert syndrome. MCQ number 13, a child is being evaluated for malnutrition and is found to have wasting. What shall be the parameter used? Obviously, wasting is said to be there if there is decreased weight for height. So remember the funda. If weight for height is low, that indicates wasting in the child. If weight for age is low, that indicates underweight child. If height for age is low, that indicates stunting in the patient. And BMI for age is used to define obesity in the child. Right? So what is the answer here? B. This topic again, always asked, or alternate year it is asked in the exam. MCQ number 14, easy one. Clues given. What shall be the likely diagnosis if a child is having chronic malabsorption with steatorrhea? So fatty stools are happening. Poor weight gain, obviously due to malabsorption. And there is dermatitis herpetiformis. So rash is happening in the patient. What should be suspected? Remember, I have discussed with you that celiac disease is a disease in which there is malabsorption, there is association with HLA-DQ2 followed by HLA-DQ8 alleles. This is something which is also associated with type 1 diabetes mellitus, Down and Turner syndromes. It is also associated with dermatitis herpetiformis, and it is associated with selective IgA deficiency. This is something I have discussed in my classes, face-to-face, online, as well as recorded lectures and DocTutorials. So clues here, malabsorption in a child and dermatitis herpetiformis. So everything fitting into celiac disease. Eczema will have a rash, but eczema will not have malabsorption. Whipple disease will have malabsorption, but Whipple disease generally does not occur in children and shows no association with dermatitis herpetiformis. And so that is the answer. MCQ number 15, a child presented to the pediatrician with malnutrition which has no lethargy and absence of edema. Non-edematous malnutrition where mental state is normal, it is marasmus. Two options could not be recalled. You don't even need to have a look at the other two options. The answer is indeed marasmus. So hallmark of kwashiorkor is PEMG, if you remember. P stands for psychomotor, yani mental changes. E is edema. M is muscle wasting. G is growth retardation. And marasmus has no edema, no mental changes, no lethargy, no rash, and no hair. And it has severe wasting. So B answer is marasmus. MCQ number 16. Look at the karyotype and tell the likely diagnosis. If you see carefully, you will find that 2 X chromosomes are present, but no Y chromosome is present. So this is a girl child. That is what you have to see. I always advise students that when you see karyotype, first always have a look at X and Y chromosome to see the gender of the patient. It is the good practice. I'm telling you a very good practice, which many people will not tell you. Whenever you get a karyotype picture, first look at the X and Y chromosome to see any aneuploidy involving X or Y chromosome is there or not, and see what gender it is mentioned. So this is a girl child, and there is no Turner syndrome or Klinefelter syndrome here because abnormal X and Y chromosome relation is present. No Y chromosome, that is absent, and two X chromosomes are present, so it is a girl child. Now count, see very, very fastly, if any trisomy or monosomy is present, you will find 18 chromosome, a trisomy is present, 3 copies are there. So trisomy 18 and trisomy 18 is which syndrome? You have the Edwards syndrome. That is the answer. What are the karyotype pictures which have been asked in the past in NEET PG and FMG exam? Have a look here. These 3 photographs have been asked. So as I said, always start from X and Y chromosome. It is easy for you to make out. In the first one, you will see that there is no Y chromosome, but only a single X chromosome. There should be at least 2 copies out of it. So this is, and if you count the total number, 45X is present. So this is a karyotype picture of Turner syndrome. Have a look at the second one. 1 X and 1 Y. So this is a male, right? This is a male. But if you count the number, you will find 3 copies of trisomy 21 are there. So this is a patient of Down syndrome. And this one is again labeled here, Klinefelter. You can start from here, X, X, Y. So, and total number of chromosome 47. So 47 XXY. So this is a patient with Klinefelter syndrome. This is a patient of Klinefelter syndrome. Right, let us move further. MCQ number 17. A 3-day-old neonate is on IV fluids. He has a birth weight less than 1500 grams. What shall be the amount of fluid? Very controversial. This was the best option I could recall from multiple students. But again, if you sit in the exam, examiner may make it 2-day, examiner may make it weight more than 1500 gram, examiner may make it a term baby, and so on. So what is it that you need to know? This question, similar question has been asked in July 23 and it has been asked in July 24. So this topic is on high agenda of the examiners. It was a tough question, but not entirely unsolvable. Have a look at this table. This table is taken from standard textbook, the book which is followed and authored by all the leading pediatricians of the country, and generally this is the book which is favored. Yes, Nelson is a standard textbook, that is an American textbook, but the FMG papers, you will find a lot of references, a lot of options seem to be, I'm not sure about it, but they seem to be, taking the Indian data. And this is what you need to know. Ghai says that less than 1500 gram, how much fluid you will give? 80 ml per kg on day 1 per day, 95 on day 2, 110 on day 3. So this is a birth weight less than 1500 gram. On day 3, how much fluid will be given? It is a direct from this table. You have to remember it. 120, then 130, then 140, then 150. And if it is equal to or more than 1500 grams, it is 60, 75, 90, 105, 120, 135, and then 150. So depending upon what has been asked to you, you will mark the question accordingly. This table has to be remembered. One small change which has happened is that AIMS protocol now says that this 150 can now go up to 180 also. Up to 180 is the word that they say. So you can go up to 180 as well. Not immediately, obviously. 150 karke, फिर 160, then 170, up to 180 on day 8, day 9, and so on, you will give. Right? So answer to this question is B. If it is a baby with weight 1500 or more, the lower column needs to be followed. Then we have MCQ number 18. Which micronutrient deficiency will have white hot spots in the eye? It is a no-brainer. The answer is A, vitamin A. So if you see, there was one tough question on fluid balance, probably one tricky question where clues were given clinically related to cretinism, and mid-parental height. If you know the formula, easy one, but if you make a calculation error or don't know the formula, tough one. Out of these 18, about 15 to 16 questions, even a student who has done pediatrics not too extensively, but in a very respectable manner, he or she should be able to do. And if it is your day and you have prepared well, you can get close to 100% strike rate as well. So what is important is pediatrics is high yielding, pediatrics is scoring, and same topics in more depth and more clinical status are being asked. So go through my lectures on DocTutorials app, or if you're attending my classes on DocTutorials or any other offline space, please follow whatever we discuss. I'm not saying that we are astrologers, but pediatrics is a scoring area. If you're playing a match and the other team is bowling economical. Bumrah is your opposing bowler, and he has bowled a maiden over. Like you have a tough questions coming from a clinical subject like surgery or medicine. Pediatrics, you can score heavily. Pediatrics, you can score heavily. If Bumrah bowls an economical over, after that, if there is a part-time bowler and you are the batsman playing, you try to hit that bowler out of the park. Pediatrics is like that subject. I hope you get the analogy, and best wishes to all the students for your future exams. Thank you so much.